Hello and welcome to another episode of Senior Spot. My name is Jenn Quinn and I'm happy to be your host. And today we have a special guest named Shannon Pinkham, and she's with Nashoba Nursing and Hospice Services. It's a mouthful. So Nashoba Nursing Service and Hospice.
Yes.
So I'm really happy to have you here.
And I'm happy
because
to be here.
We have a lot of viewers that do need some clarification and would love to learn a little bit more about Nashoba. I just refer to you as Nashoba Nursing. It's just my kind of shortcut.
Yep. That's what most people
And most people probably recognize that. So I would love to kind of get a little history lesson because I know that we have a lot of folks that lived in the area a long time, and just learn a little bit more about the history of Nashoba Nursing. And what's really interesting about your role is that you're the business development manager and you're an LPN.
Yes.
So you have the business and the medical all rolled into one. So yes. I'd love to hear the history from you.
So Nashoba Nursing Service and Hospice is it's under the auspices of Nashoba Valley Board of Health. The Board of Health started in 1931 under the guide of Harvard University, actually.
Oh.
It was started in the Nashoba Valley community, and it helps with all of the community, the water department, and community nursing. Then in 1966 they started their home health department.
Okay.
And so that's what we are. That's what I'm here with. We have home health, which is skilled nursing, which has under its umbrella has nursing, physical therapy, occupational therapy, speech. We have home health aides. We have a social worker. And then another arm is hospice and palliative. Hospice has under its umbrella has the nurses, sometimes physical therapy and occupational therapy to keep somebody at their baseline, but not usually. And then they have aides. They have spiritual guides, bereavement counselors.
Oh, wow. Now that's unique. That's
Yes.
not something you always hear about, and that's part of the journey, especially if it's an end of life situation with somebody on hospice. I mean, that's a real integral part of it.
Yeah, and it's really it's great. Our bereavement and spiritual person it's the same person, and it's non-denominational. If there's something specific, a specific religion that you want to be introduced back into your life or to keep into your life, we absolutely can reach out and do that. But this is non-denominational. They do some Reiki, some massage therapy, and they just have a lot of discussions about end of life and about what you or your family, because it's a lot about the family as well.
Sure.
About what the family needs spiritually, about talking about end of life and what they want, whether they want to write letters to family members, or if they want, how they want to be remembered and things of that nature.
Well, because obviously you have all of the medical piece, but it really is so much more than that. And I know, in being in association with Nashoba Nursing and Hospice, and I'm just going to call it Nashoba Nursing the whole rest of the episode, because that's what I call it. It's funny how you get used to something like the Boston Garden. I could never call it anything but that. But so Nashoba Nursing. So when it all began, you obviously started off as a Board of Health, and then you've expanded and added all of these complementing services as well. So I know that you started obviously in 1931, but that was in sort of an immediate area. Now the area certainly has grown. So can you tell us a little bit about the towns that you service? And I know it's not limited to only these towns, but give us an idea of what your catchment area is.
So we do service some of the towns in Middlesex and Worcester counties. So it's the Nashoba Valley area and then the surrounding cities and towns.
Westford clearly falls in there.
Yep, Westford, Littleton, Shirley, Ashburnham, Ashby, Stowe, Townsend, Pepperell. I'm going to get stuck up. Fitchburg, Leominster. We go into Chelmsford as well.
Yes. Great. Well, and it's interesting. The reason why I asked that is because people like to use services that are close by and that are very well established, which clearly, given the dates that you shared, is very well established. And you talked about the different services, and I think a lot of people are familiar with the idea of having some skilled nursing coming into the home after they've had, an injury, an illness, and they have that. That's pretty straightforward. But The hospice arm is something that people are really unfamiliar with, and I would love for you to share a little bit more about, what exactly is hospice, what exactly is palliative care. That's an even newer term that can confuse people. So I think it would be really helpful for our viewers to understand palliative care and what was often referred to as a bridge, to hospice. And just kind of understand a little bit more about what those services entail. So I'll let you take it from here.
So palliative care, it's a good way to go from palliative to hospice, because that's pretty much how the progression goes. So palliative care is still considered a skilled need in terms of insurance and Medicare, basically. And what it is that palliative treats symptoms. So it helps with pain management, for example. It helps for those who are receiving chemotherapy and have a lot of nausea, decreased energy, a lot of the side effects. It helps to treat those symptoms. The thing about palliative is it allows those people to continue to seek curative care. So they can still be choosing to treat the disease,
but putting
whether it be
themselves
chemotherapy or
in a more comfortable.
And yes, so they have a nurse or a physical therapist or a home health aide that's helping them to treat those symptoms of that the disease process and of the treatments that they are receiving.
Okay, so that word right there, I think, is probably the best takeaway word of one versus the other. Is you're actively being treated during palliative care during that phase. So then. You mentioned, we talked about quickly a bridge. So what is that? Like,
so
I'm such a visual person. So I love the idea of a bridge.
Yeah, absolutely. So a lot of times when we think of palliative care, we think of a person who has a diagnosis that does have that there is an end point, so to speak. It's a terminal illness.
So there's a discussion around the fact that there is an imminent end of life.
Yes. So the perfect example, which is most used as a cancer patient. Somebody who has cancer and it is a terminal illness, but they are still choosing to seek treatment, which is completely fine. That's what they want to do. So they choose palliative for this time. And then maybe as the progression of the disease goes along, or maybe unfortunately the treatments that they've been having aren't curing them, the person decides, you know what, I'm going to choose to no longer seek treatment for the disease. And then so that's where what we consider the bridge. So if you start in palliative and then you still have the same nurses, the same home health aides.
See, that's marvelous.
Yeah,
that is.
That way you're not starting with another agency.
Consistent.
And it's, absolutely, consistency. It's a nurse that knows you. A nurse that's been speaking with your doctors, who's been speaking and knows your family. Because a lot of times when it becomes end of life, not always, but oftentimes hospice doesn't just care for the terminally ill client. It helps to care for the family.
Absolutely.
And actually something that a lot of people don't understand about hospice is that hospice continues 13 months after the patient dies.
Okay,
so we check in with family members.
Like what would be some components that would be offered after someone has passed and for 13 months? I mean, that's a really generous amount of time to be able to continue to get support. What types of support?
So our social worker, our bereavement counselor, who is also the spiritual counselor, goes out and touches base with those family members that choose to. It's not anything that is forced upon.
Right, because
some
not
people
everybody wants to. Everybody deals with things in a different way.
Exactly. So if they choose to, they have bereavement groups, they have support groups that they can go to and that they're invited to. And again, they have the access to the social worker, the bereavement counselor, and the spiritual guide, spiritual counselor.
Well, and I'm so glad that you emphasize that even though it's two different things, the idea of the bridge is the fact that you're going to continue to work with the same professionals, the same support staff, which is really, that's huge, because when you think of two completely separate things, you would think, well, I'm going to end something and start all over again. And really the most important thing at that point is comfort, continuity, consistency, all of those features that, kind of
absolutely
you build the bridge for them, which is great. So, I guess my other question is, besides learning between the difference between the two, which I think you so succinctly summarized it, which makes it really easy for our viewers to understand. One of the other questions might be, how do you typically get started? How does it happen where you come upon Nashoba Nursing? I think the straightforward skilled care, let's say that, I hurt myself, I come out, I need to have a little bit of, OT, PT at home. That's pretty straightforward, but how does all of this get started? How do you get connected for, say, the palliative care and the hospice piece?
So in terms of how we are known, it's a positive for us is that we are so tight-knit with our community. We try to do community services, we try to be in the hospitals, we try to be at health fairs. We really want to be in the community. It's all about giving back to our community.
And you do.
And being a part of the community.
And you do. I mean, it's very clear.
We are not a huge chain. We are a part of this community. And so learning about, how do you learn about palliative or hospice care? We do go into hospitals, we do speak with doctors, we have educational programs, we have some educational offerings in terms of different end-of-life care, hospice, and we go into council on aging, things of that nature, just trying to be present.
Yeah, well, and spread the good word and let people
Absolutely.
know that this is a really valuable service that they have, and I'm going to use the word choice because I wanted to kind of bring that up too. Because often people will be faced with being offered palliative care or hospice services. They're typically being offered those choices in a situation which isn't always, it's usually some sort of chaotic or some sort of incident that brings it upon, brings the decision. It's not as typical to be in a doctor's office and have a calm sort of discussion and then you're offered some choices. So I want to go back to the idea of, when you're in the hospital and you're having discussions about that people know that there's always a choice.
There is, yes. Part of the Massachusetts home care regulations is that there is choice. Nobody can tell you who you have to choose. You have the right to make that decision for yourself. So whether you want to, so to speak, interview, you can have multiple hospice agencies come in, multiple home care agencies come in and do like an in-service for you to give you information, informational.
It's an in-service and sort of an interview too, to see if you want to
and you can see who you
work with someone.
Exactly, absolutely.
Yeah, I know. I mean, I always feel very comfortable in referring and mentioning to folks, Nashoba Nursing, and and giving them a choice. And people are going to. They're going to see if they connect with you and your philosophy, and a lot of it just comes down to, the people. What you see is what you get.
Yeah.
I love the idea that you're a business development, but you're also an LPN, which I think is huge. Not all people that are out as a spokesperson have that medical background too. Yeah. So I think that really speaks volumes about who the people that are representing Nashoba Nursing, who they are and what they're doing. Yeah. But I like the idea that there's specific specialties, but there's always choices that they have.
Absolutely.
So tell me a little bit about maybe a success story that that you can think of that that you're really proud of. Anything that just top of mind. It could be anything. It could be skilled nursing, it could be palliative care, it could be hospice, any of the above. Something that you say, wow, I'm really proud that I was part of this recovery, this end of life. What would it be?
So there's a couple on my top 5.
I was going to say, I'm sure you have more than
one of the big things with home care and is trying to keep people out of emergency rooms.
Yes.
So and one of the big things is trying to keep, if somebody comes out of a skilled nursing facility or a rehab, trying to get them to go back there as long as there's not some type of an emergency.
Right. So let me stop right there, because that's something that people should know as well. In order to not have to be readmitted to the hospital, which we all know is usually pretty traumatic.
Yeah, absolutely.
It can certainly, increase a decline in terms of somebody and their prognosis. But, you mentioned that they could go back to this. So that is worth mentioning again, because people don't realize that.
And again, yes, absolutely, yes. Because who wants to sit in a waiting room for 8 hours at an emergency room for something where they're going to put you in a bed and say, oh, you're going to go back to where you came from anyways.
Right. Why not just go back to the folks that you're
Yes.
already comfortable with and know your history and
So
such?
one of the big things we've been working on is educating our nurses, educating our clinicians, all of our clinicians, but also educating the physicians and the doctor's offices in the community about this as well. So we had a client who had a decline. Nothing emergent though, nothing that required an emergency room, because a lot of times people use emergency rooms incorrectly. It was not an
Right, you
emergency
panic.
room. Yeah, exactly.
Absolutely.
So the patient was had a decline, and we called the facility that they had come from, and the facility said, absolutely, there's a bed, send them here. We called the doctor's office, and the doctor's office it took them a little bit, and at first they had initially said, nope, they need to go to the emergency room.
Because that's a typical first
Yeah.
initial reaction.
Right, because you think emergency room. So this patient was literally in an ambulance on their way to the emergency room, and we were able to reroute the patient to avoid sitting in an emergency room, to avoid having to go through the hospital stay and then
just all the
get
questions
transferred
that
back.
get asked all over again.
And we were
It's a
able to
lot.
get them redirected in an ambulance back to the rehab facility.
That's huge.
It's
That's some influence and pull there, and that
and
means
it was
you
so
really know your
exciting on a
stuff.
Friday afternoon at 4:30.
It's
and
always
we were
a Friday afternoon at
abso-
4:30.
yeah, but we were all so excited about this small task that we were able to, as an agency ourselves, and then working and educating with the physician's office, with also having the rehab working with us and saying, yes, absolutely, send them back. So it was just a great collaborative.
It is.
Yeah.
Oh, that's exciting and so comforting for the person in the ambulance, but also their family who's
Yeah.
thinking, are we starting this vicious cycle all over again? So it's really kind of breaking the cycle and knowing your stuff. It really just comes down to and knowing your patients, knowing what their history was, where they came from. Because imagine if you didn't know that.
Absolutely.
Then
and the nurse knew. The nurse called us, and that's what started it off. So
good communication.
Yeah.
Which is outstanding. So I love that success story. That's great, and
Yeah.
I think it also lended itself to an opportunity to tell our viewers too. Again, just like you have choices, you also don't necessarily ought to always have to go to the emergency room.
Yeah.
If you've had an experience just prior to that you could go back to where So look at all the things you're telling
Yes.
people and educating people about. So. So going back to just thinking about, how things happen. So let's say that I have an aunt that is going to need services. And we say, this is great. Nashoba Nursing is going to provide services. My aunt fell, she broke her hip. And maybe it's a discharge right from the hospital, which isn't as typical, but it's always could happen. Yep. So in one sense, it might come right from the hospital, but most of the time it might come from a rehab. So tell me what it looks like when the person leaves the rehab and goes back to the home. We say that they're going to have these services. Can you give us like an example of somebody like that, what they would have when they got home?
So let's, for example, if a hip or a knee, some type of an ortho, the referral comes from the rehab. So usually their case management department. So either myself or a staff in my office will have a conversation with them, or I might go down and actually introduce myself to the client so that they kind of have that face. They know who it is. Sometimes the clients are unavailable, but you always make that effort.
Absolutely.
And then if they're discharged, usually the following day, so that evening, we give them a call and just to let them know a nurse is going to be coming out there or a clinician will be coming out there to see you. And then we try for the next day to have a clinician start the plan of care, to start the care for them. Usually if it's an ortho patient, they'll usually have a nurse. Usually physical therapy will be ordered for them. And then we always assess for whatever other needs.
Sure.
So occupational therapy, home health aides might be needed. Depending on the situation, they might need some help with social work, whether they need help with insurance or planning, life planning.
Okay.
So things of that nature.
So and when you're in the homes, I mean, you're not allowed or able to stay forever, even though with some clients you probably want to.
Yep.
So, I mean, if you were to give like an average or an approximation of the amount of time that typically your services are needed in a home, which would be considered like a VNA services. A lot of people will just use that global term, visiting nurse association. So that's what you are. So about how long would you say is typical for you to be in the home helping?
Per visit, do you mean, or just in general?
Actually, I'd love to hear both. So.
Okay, so per visit, and both of them are very much dependent on the need.
Yes, but I'm thinking just your average, like ortho is
so
a
your
good
average,
example.
again, it's very much personal, tailored to the client. Your average visit is anywhere between a half an hour and an hour and a half to 2 hours, depending on the need. Not normally the extreme 2 hours, usually between a half an hour and an hour.
You'd be really tired doing PT for
but you never
2
know.
hours.
And then the average length of stay for care, we generally have a plan of care for 60 days. And then what happens is some people graduate from that before 60 days, and that's great because we want them to graduate. That's the goal, is to keep everybody in the community, get them healthy and back to their baseline. But if for whatever reason somebody isn't progressing as quickly as we'd like, we do have the ability to recertify them for another 60-day plan of care. And if that's needed, we have to show the need, and the doctor has to agree with the plan of care.
Absolutely.
But that is a possibility. But we usually work on about 60-day plans of care.
Okay. Well, I love the idea that you prefaced it all by saying that everybody's different. There's no one size fits all.
Absolutely. You might be a 50-year-old person that is very healthy regularly, but you just had your knee done. So you only need a short amount of time, and you're going to heal quicker than a 90-year-old that fell and broke a hip, or that has a chronic illness that keeps putting them in the hospital for whatever reason. So sometimes home care helps them to stay in their home, and hopefully helps them to stay out of the hospital and less frequent hospital.
Well, and I'm really glad that you broke it down. You took my question and broke it down perfectly. Per case, how long, but also per visit, because I think that also is a misconception that people say, "Oh, I'm so excited! I'm having Nashoba Nursing coming," and they have this incorrect notion that you're going to be in there every day, all day. So I think it's great to even kind of explain a little bit about what people's expectations are versus reality.
And it's not every day. So especially with hospice, I think that is an incorrect notion more so. So with all of home care, whether it's the skilled home care, palliative, or hospice, the idea is to teach either the client, and if the client's unable to learn, to teach a caregiver how to do a wound, how to help with medications. And the biggest part of skilled nursing, or one of the biggest parts of skilled nursing, is educating them so that they can do it on their own, so that they can continue to be in the community on their own. One of the biggest pitfalls, I think, is when people think hospice, they think, oh, there's somebody here 24 hours.
Right.
And that's not usually the case. We are there absolutely to educate the family members and the clients and the caretakers, because sometimes they're not family members, on how to take care of that person in the end of life, whether the end of life is 6 months, 6 weeks, or 6 days.
Well, and you're so accessible too. I think knowing that there's somebody on the other end of the phone line that's going to be able to answer questions, because especially like you're referring to with the hospice, end of life is there's so many emotions, and it's scary, and it seems like I love it, your disposition. You're calm, you're collected, and that's the role, is to help people stay calm and collected, and to guide them to whatever services that they need at the time. So I think that's important for people to know, that you're going to be there, but you're not going to be there all the time.
Right. We are accessible 24 hours. And so if there is a decline at 2 o'clock in the morning, and we've taught you a lot, but in that panic moment, people panic. It's natural. Nurses who have been taught and trained panic, when it comes to a family member.
Right, absolutely.
Because everything is different when it becomes who you're,
It is.
So there is somebody there on the other end of that phone, and if need be, if it warrants, there will be a visit made.
Right, and and we're always trying to encourage people, just call.
Absolutely.
And some people won't. They'll say, oh, I don't want to bother anybody. But you want them to call. You want them to ask the questions, because, you want to help solve whatever it is all along the way, so it doesn't end up being something monumental.
Absolutely. And a lot of times too, you know, we talked about, I just got, you know, we're there for somewhere between a half an hour and an hour and a half on average, right? Every other day. Well, that's not, there's 24 hours in a day.
Right.
So how somebody presents in those 45 to
Very good
60
point.
minutes is a very different display of what can be, whether it be somebody with dementia who's sundowns 6 hours later,
Very
or
good.
somebody who has pain who took their pain medication right before you got
Right.
there, but then in a couple hours it's just, you know, the pain is out of control, or a wound that just doesn't look right 6 hours later. So call, definitely.
Right.
That's the,
Yeah,
yeah, absolutely.
And I think it's and that's a perfect way of describing it too, because sometimes, you know, we'll go in and visit someone and someone will say, oh, they're having such a good day today.
Yep.
And then the next day might not be. So knowing that you're just a phone call away is huge. And that applies for anything. That applies for the
Yep.
skilled nursing.
Absolutely.
And the palliative care and the hospice. So any types of those skilled services,
Yep,
which is
absolutely.
great. So I love that, you know, you're local. You know, it began in 1931. I mean, that is, I mean, talk about a great track record. Not a lot, many places open and close, and I mean, obviously, it's been very well sustained.
Yep.
And I love the fact that but it hasn't stayed the same. That as things have changed, like you talk about the education and making sure people can go back to a rehab instead of the emergency room, you're constantly updating along with
Yeah.
what things are going on and what the best practices are. So, so on one hand, you're well established in something that's 1931, but on the other hand, you're completely modern in terms of the thinking and
Yeah.
all the services that are available, and right in our backyard, which is great. And I know that they're going to put up the website, you know, at the end, Nashoba. This is so easy, nashoba.org.
Yep.
I mean, could it be any easier?
Yep.
I love that. That makes it really helpful. But I'm so delighted that you came in, and most importantly, I think to kind of summarize it is that when you describe the skilled services, you have obviously your VNA services, you have your palliative care, but that's when someone's still being treated.
Yep.
And wants to have the treatment, but then you have a bridge and you stay with the same team of people if you transition into
Yes.
hospice. That's marvelous, you know,
Yeah.
and those are huge takeaways, and people will know that Nashoba Nursing is going to bring them to the place where they want to be in recovery or the place they want to be at, you know, at the end of life. So thank you for coming, Shannon.
Thank
and
you
it's
for having
exciting
me.
to hear the business piece of it, but also the medical piece of it, and you rolled it all together just perfectly.
Thank you so much.
Thank you for coming in.
Thank you.